Hey everybody, Professor Long here, your A&P professor doing your A&P lectures. This is respiratory lecture number 2 for my 2402 class. This is going to be over the definitions. If you're in my class, we're going to be in the note set on page 70. I'm going to go over the pharynx, the definitions on page 70, and I'm going to try to do some of page 71 if I can fit it all in. As you know, we're in the coronavirus shutdown, so I'm working from home. You guys are working from home. If you hear any bells or whistles or dogs barking or kids talking, I'm going to try not to lose the video if I'm 15 or 20 minutes in. So we may have to deal with that. Anyway, I'm trying to do these when no one's available, but some days it just doesn't work out that way, and I got to do what I got to do. So here we go. We're going to do the respiratory system. So we covered the upper and lower respiratory tract earlier. And we talked about the structure called the pharynx. As air enters through the nasal cavity, through the nares and the nasal passageways, and gets down past the internal nares, the upper part of our throat, kind of what you see if you go ah and you look in your throat, you're staring into what's called the oropharynx, which is part of a larger tube called the pharynx. As a matter of fact, let's go ahead and talk about it a little bit here. If I look at the anatomy, if I have someone's nose and mouth like this, the external nares leads into the nasal cavity, comes down to the internal nares, and then the oral cavity and the nasal cavity are separated by the palate. As you know, there's bone most of the way back here called the hard palate. We did that in lab. And then this would be the soft palate, the muscular part, kind of the squishy part at the back of your throat. And then the little punching bag hanging down back there is called the uvula or uvula. So the pharynx really begins right about at this opening right here, which is where the internal nares is. And then the tube comes down this way. Of course, your tongue would be in here and would fold back and cover some of this. But the tube comes down a short ways, and then it will split. One of the branches is called the esophagus. I'm not going to focus on the esophagus. That's the next section we're going to do, the next series of lectures, which is the digestive system. But that would lead to your stomach. That's where food would go. Your respiratory and your digestive tracts share the pharynx in common. And then right about here would be your larynx, and then you would have all the tracheal cartilages making up the trachea. The tube, till just about where it splits from here to here, is all called the pharynx. A lot of people want to say pharynx, but it's pharynx. Now, I can actually divide the pharynx into 3 regions. Now, I'm going to change colors here so that you can see it. But this area right here, I'm going to label it A, would go from the internal nares to about where the uvula is. And the area that's A would be called the nasopharynx. Okay? Sorry. But the nasopharynx is called that because it connects to the nasal cavity. If I go to the tip of the uvula to about the bottom of where the fauces is, which is the opening between the oral cavity and the pharynx, this area here, B, would be called the oropharynx. Okay, this is sort of a review of the anatomy of the models, the flathead model in lab that we look at. And then this little area here, from about where the fauces is, or the end of the oropharynx, all the way down to the larynx, or right about where it splits, is called the laryngo, and some people say laryngopharynx. And that's because your voice box obviously is called the larynx. So those are the 3 areas of the pharynx. Now, if you think about them, if you look at the table in my note set, the nasal pharynx is designed only for air to pass through. It's really not designed for food to make it up in there. And the oropharynx and part of the laryngopharynx are where both air and food can travel. Now, if you go back to a simple concept that we covered in part 1 when we were doing all the tissues, all the surfaces and linings of the body, external and internal, from there, if you go the other end, are all lined with epithelium. If you can reach in from the outside world without cutting the body and tickle it, your ear cavity, your nose cavities, all the cavities would be lined with epithelium. Now, we tend to have simple epithelia, thin layers, where we want permeability, where we want stuff to enter or exit the body, like the respiratory exchange surface. The digestive tract is going to have simple epithelia where nutrients and things can get across, we can be absorbed. Where we need protection, where we can have abrasion and scrapes and scratches, we tend to want to have thicker layers for protection. If I scrape a few cells off, I'm still not down into the vascular layer of the connective tissue, the lamina propria. So we tend to have thick layers where we want protection. So if you think about the respiratory passageways, you can stick your fingers in here or here, and anything that gets in can scrape the walls. So initially, the nasal cavity starts off with some stratified squamous epithelium, but it quickly transitions to the pseudostratified ciliated columnar to push stuff out. And as we enter the nasopharynx has a lot of pseudostratified ciliated columnar epithelium for the secretion of mucus and the pushing of things out so that it prevents dirt and debris from clogging the lungs. Now, as we move to the oropharynx, it's designed for air and food. And because some of the things we eat, like potato chips, a Dorito, or a popcorn kernel gets caught, and you're sitting there going, you can scratch everything. So we want stratified squamous epithelium. And there's a transition from the pseudostratified near the end of the nasopharynx into stratified squamous epithelium, and that continues into part of the laryngopharynx. The laryngopharynx has an area where both air and food, but an area where only air can go. So it's a little bit kind of both. Where air and food can go, we want that stratified squamous epithelium for protection, but then it quickly starts to transition back into pseudostratified ciliated columnar epithelium and begins the mucus escalator passing into the trachea and the rest of the respiratory tract. So if you're filling in the table at the top of page 70, then the nasopharynx is going to have some stratified squamous because it's for air only. It's going to have pseudostratified ciliated columnar epithelium because it's got air only. The oropharynx is going to be stratified squamous because food and air can pass. The laryngopharynx is going to be a transition from stratified squamous to pseudostratified ciliated columnar epithelium. And then once we're in the trachea, it's only for air, and that's pseudostratified ciliated columnar. Now that you got that, I'm going to erase this, and we're going to talk about the definitions on this page, because the definitions on this page are going to help us understand a lot of what we're going to talk about and some of the more complex figures we're going to get into. So if you're using my note set, these are the definitions that I really want you to focus on. So the first one is hypoxia. And anytime you look at hypo means under or below or less than, and the oxia refers to oxygenation. So using my shorthand, this would be a decreased concentration of oxygen to a tissue or in the blood. If you're hypoxic, then you're below your oxygen levels. You have a low oxygen concentration. If we were talking about blood, we'd be measuring it in the plasma. If we were talking about tissues, we'd be talking about tissue hypoxia. And as you guys should be aware, our cells need oxygen plus glucose. They run them through mitochondria to make 36 ATP, which, by the way, gives us carbon dioxide and some water. So this is the good stuff. This is kind of the bad stuff. If we don't get the carbon dioxide out, it will enter into some dangerous chemical reactions if it builds up in a high enough concentration. It will react with water and turn into an acid, dissociates, and can change your body's pH, and we can get what's called respiratory acidosis or respiratory alkalosis. We'll talk about those later. But anytime we have decreased oxygenation, we have decreased energy. So now, the next definition is going to be anoxia. The an means without or not. So anoxia means no oxygen. That's like zero oxygenation to a tissue. We've cut off the oxygen flow. The next one is a pneumothorax. Now listen, the next two definitions I'm going to give you are really pretty technical. And a lot of people are going to tell me I'm wrong, but I'm not. But it's been taught a certain way for so long that I think people confuse these two terms. A pneumothorax itself is nothing more than a hole in the wall of the chest cavity or the thoracic cavity. So, if you broke a rib and it was sticking out of the skin, you'd have a pneumothorax. If for some god-awful reason you got stabbed or impaled with an object, or you got shot through the thoracic cavity, you would have a pneumothorax. Pneumothorax is just a hole in the wall of the chest cavity. But it leads to the next definition that's on the list, which is called atelectasis, or some people say atelectasis. Okay? Atelectasis is the technical term for a collapsed lung. Now, because when we learn the anatomy of the thoracic wall and how the lungs and the membranes are somewhat stuck to the chest wall cavity, since there's an adhesion that occurs. Actually, it's cohesion from some water molecules, but the two membranes are stuck together very tightly. So wherever the chest wall cavity goes, the lung goes. And if the two outer parts of the thoracic cavity do this, expand and contract, the lungs will expand and contract with it. We're going to talk about that with breathing. Now, if I poke a hole in the chest wall and air gets in between those two surfaces, they will break away, and that would cause your lungs to collapse. So almost always, there's a very rare instance where a pneumothorax may not cause a collapsed lung, but almost always a pneumothorax results in atelectasis or collapsed lung. So those two definitions get confused a lot. Anyway, I wanted to make that very clear to you. So I'm going to erase these terms. We're going to go on to a couple of others. So when we talk about what's called eupnea or eunia, some people pronounce the P and some don't. But eu always means true. And the pnea refers to breathing. So we call this true breathing, or another name for it is quiet respiration. Oops, give me a second. Got ahead of myself. So quiet respiration is when you're breathing at rest. If you were sitting quietly reading a book, you're going to inhale and exhale. You're really not going to hear the air coming in and out. And it's a rather simple process. We call that eupnea or quiet respiration. The opposite of that is going to be apnea or anea. Again, a and an mean not. So you're not breathing. This is a temporary stoppage of breathing. We call that apnea. So, oddly enough, there's a certain amount of apnea that happens with each breath. When you inhale, there's a fraction of a second of apnea where you stop breathing, and then you exhale, and then there'll be a little bit of apnea, and then you inhale again, apnea, exhale, apnea. But it is very, very short. You usually hear about apnea when you hear about sleep apnea, people who have extended periods of apnea while they're sleeping. For example, if someone were snoring, you don't hear someone go in and out very rapidly. What it would be a long, slow breath. And you hear that extended break of sleep apnea. The danger of that is we stop oxygen flow and carbon dioxide exchange. And so we're depriving ourselves of energy. We could be building up some carbon dioxide. And therefore, people who have bad sleep apnea tend to be more tired in the morning, get very tired, and have a harder time getting going for lack of energy. Anyway, so that's apnea. Hyperpnea is, since you know the term hyper means more than, so hyperpnea is what we also call forced exhalation. It's really the opposite of quiet respiration. In forced exhalation, we are actually forcefully getting extra air out. It's a little tricky to think about, but when you think about it, when you go to get on the elliptical machine at the gym, or if you go exercise, you don't start breathing rapidly first. At least most of us don't. Some people do, but before you get on the machine, your respiratory rate, your breathing rate is rather normal because your cells are burning the same amount of oxygen, producing the same amount of carbon dioxide, and we don't have to breathe faster to exchange those two gases. After you get a good 2 or 3 minutes into the exercising, what's actually happened is your skeletal muscle cells have burned more of the oxygen and glucose and produce a little bit of extra carbon dioxide. We haven't started delivering extra oxygen yet. What you may not know, I don't know if you recall this from part 1 A&P, but skeletal muscle cells have a protein similar to hemoglobin in blood. Hemoglobin, as you know, binds oxygen and can bind some carbon dioxide. But skeletal muscle has a similar protein called myoglobin. Myoglobin can bind a small amount of oxygen, and so your muscle cells can store a small amount of oxygen, and they store glycogen, glucose, in the form of glycogen. And when we start to get into increased activity, before our heart and our system can start breaking down glycogen in the liver and increasing respiration and delivering all that oxygen and glucose to the muscles, they have their own little backup reserve. And so they'll start burning their own oxygen and glucose and generating excess carbon dioxide. It's that excess carbon dioxide that actually drives breathing more so than oxygen does. And when we get the excess carbon dioxide coming back to the lungs, we actually exhale extra first, getting the excess carbon dioxide out, and then we take a bigger inhale. We're going to talk about this in the next series of video, the next video, respiratory lecture number 3. But hyperpnea or hyperpnea is forced exhalation. It's the breathing that happens when you're exercising or have physical exertion or stress, sympathetic activation, that huffing and puffing and panting. Now, let's go on to the next few definitions. I don't want to spend too much time on this stuff. Com means with, and ply means to move or go along with. So compliance means to go along with, right? So if you comply with something, you're going to go along. So compliance in this situation is the ability of an organ to change shape to accommodate. Sorry, it's harder to write neat on the edge of the board, but that's the word accommodate here. I'm trying not to lean into your screen too much and show you my back, but to accommodate changes in volume. So some of our organs have to be able to change shape to change volume. For example, if I had, let's say, like a drink container, but the ones that are made out of metal, they look just like a plastic bottle, but it were metal. The metal would be hard. It would not be able to expand or contract. I can't squish it very easily. If I blew into it really hard, it would not expand. If I take a plastic bottle, I can crush it, and then I can blow into it, and it will back expand. The plastic bottle has a lot more compliance or ability to change shape. The metal bottle would have almost no compliance under standard conditions anyway. Our lungs and many other organs, your bladder, a lot of your digestive tract, but our lungs have the ability to comply, to expand and contract with changes in volume. It's kind of how we breathe, and we're going to get into that in the next video. So when you go to the doctor or the hospital and you see that little plastic tube that has the hose that you blow in with the little ball that goes up and down, respiratory therapists use that to check your compliance. If your compliance is compromised, if you can't expand and contract the lungs, you can't inhale and exhale and get as much gas exchange, and therefore you could have problems with healing and recovery and things, energy. So they're always checking your compliance to make sure that you're ready to go home or that your lungs are able to function properly. So anyway, that's what compliance is. The next 3 definitions, I'm just going to rip them out real quick. They're all related, and they're all going to lead us to the next video, because I'm going to make a big picture of that and put a lot more detail in that video for you. Again, I'm trying to keep these less than 25 minutes if I can. So anyway, pulmonary ventilation. Okay, I'm going to give you a specific definition for this, and you should know it. Pulmonary ventilation simply means the movement of gases, and we're talking about what we call the dissolved gases. I'll explain that shortly. To and, that's the little symbol for and, from the gas exchange surface. Now I know I'm leaving certain words out like the, but it's the movement of gases to and from the gas exchange surface, or essentially from the atmosphere to the alveoli and back out. So it's the movement of gases to and from the gas exchange surface, or the movement of gases from the atmosphere down to the alveoli, the gas exchange surface, and back out of the body. Again, ventilation does not always mean breathing. If you took a deceased person and compressed the chest and let go, you would move air to and out. That's the P in CPR, cardiopulmonary resuscitation. Well, the P is the pulmonary ventilation, sort of. You're trying to breathe for someone who cannot breathe for themselves to keep oxygen flow to the brain and the heart and the tissues. So that's pulmonary ventilation. It's simply moving the air to and from the gas exchange surface. Now, I'm going to erase this because I need some room. I don't have a big enough board. I think I'm going to go buy a bigger one soon and expand my teaching area, much to my family's chagrin because it's eating up my dining room, but oh well. The next definition that's on the list is external respiration. Okay. So, external respiration is the exchange of gases. Again, we're talking about what are called the dissolved gases, those gases which have the ability to dissolve in our blood. I'll talk about solubility in gases and things in a little bit. But it's the exchange of gases between the atmosphere, which is the outside world, external, and our blood. We usually think of this as plasma, but it depends on which gas. So as we exchange oxygen from the atmosphere into our bloodstream, and from our bloodstream we get carbon dioxide out into the atmosphere, that's called external respiration. The exchange of gases between the atmosphere and our blood. It's happening at the external layer. Now, I'm going to just change one word. I'll use a different color marker because I don't feel like writing all this out. But the next definition is called internal respiration. And this is the exchange of the dissolved gases between, here, let me erase that properly, the blood and tissues, or sometimes instead of tissues we say the interstitial fluid, that fluid flowing between the different cells within a tissue. So when I get the blood from the lungs down to the tissues, I'm going to have an exchange between the tissues. I'm going to get oxygen out of the blood into the interstitial fluid and the carbon dioxide from the interstitial fluid back into the blood. We call that internal respiration. So these are the definitions. There's plenty more that we could cover, but these are the ones I really want you to focus on and get down, because in the next lecture or two, we're going to use a lot of this terminology. And there's going to be probably 2 to 4 more lectures to cover all the respiratory system. Again, I'm chopping it up so that I can try to keep them short, tolerable, and you can work through your worksheets. Anyway, I hope you had as much fun as I did. Hope you learned something. Hope you gleaned some information. And I'll see you in the next video. Thanks for watching.